Well, thank you so much, Robert, and for the invitation to be here, and to greetings to all colleagues, especially colleagues coming from Ukraine. It's wonderful to see you again, those that have previously met, and we have only been able to imagine your situation up to now, but now we see you in person. So I'm very happy to have the opportunity to talk to you about some work that we have been doing with the World Psychiatric Association, and precede that by displaying a photograph I took just yesterday, which I think is late summer, or if we say early autumn in Vilnius, a beautiful place to come back to, having been here 5 years ago. So I'll begin by saying a few words about the World Psychiatric Association and its work with the advice of engagement of service users and family carers, and move on to looking at the program of the association on implementing alternatives to coercion and our understanding of the situation and how we can move forward with that. And the continuing efforts of the program, it's really a recruitment effort to see whom we can encourage to assist us in this work. So first of all, not everyone will be familiar, but the World Psychiatric Association is an association of mental health societies. It has membership in 120 countries, mostly the National Psychiatric Association. And it works through a network. Its strength comes in that way. So the member societies and other international associations, non-government or government organisations and research institutions. And it's the links that it encourages and is able to achieve between professionals or practitioners, service users, family carers. And it has a formal relationship with the World Health Organization, so it's a non-state actor. And I'm speaking here in front of a former president of the World Psychiatric Association, Professor Sartorius, as well, is my certainly one of my heroes that I've found an important guide over the years. And it's this network that allows the World Psychiatric Association to consider tackling global challenges, and particularly access to care and the quality of care, and including for people living with disadvantage and adversity. In much of what I suppose the caricature of psychiatric associations is that they are concerned with the needs of psychiatrists, and of course the World Psychiatric Association is. It wants psychiatrists to be able to contribute to strengthening response to mental health needs in communities. And that includes, as you've just heard earlier today, people who do arrive looking for care, but also people who have little access currently to care, and those who which live in conditions of life that are not conducive to good mental health. So the World Psychiatric Association has a vision in which people live in conditions that promote mental health and have access to mental health treatment and care that meet appropriate professional and ethical standards, integrate public health principles and respect human rights. Now that's pretty much as far as we can work out has been the underlying principle of action for the association since its formation after the Second World War in 1950. In more recent years, the association formed a relationship with service users and family carers that was more distinct than had existed previously, and asked groups to join it in considering how to imagine best practices in working together. And this was in recognition that we can do very little without this relationship, without this engagement. And that also family carers as well as service users have needs that we need to understand as well as possible. And 10 years ago, recommendations were prepared for the international mental health community about best practices in working together. And there were 10 recommendations, 2 of which here give the flavour of that, but that respecting each other is the basis of successful partnerships, and that everything concerned and relevant to the lives and care of people with mental disorders need to be developed together with them and their family carers or other informal carers. And these recommendations have been now embedded in the association's ethical declarations and its new code of ethics. So the association formed a task force in 2018 to consider how to implement alternatives to coercion. And I'll begin by thinking about what do we mean by coercion. We decided that coercion is widespread, and in countries with little provision for care for people living with mental ill health, that can often mean detention or confinement in family homes or in other settings in communities. And we felt, of course, this needs attention and action, but the first consideration would be how to consider the needs of people with access to mental health services. And there are a number of images there of contemporary and medieval care, and sometimes it's difficult to tell the difference. But the confinement can be sometimes less obvious. In some settings there is community detention, and in others there is confinement and physical restraint in hospital settings or in prisons. So what do we mean by coercion? So the definition that this task force developed was a range of interventions that are authorised or put into place directly by mental health professionals. That might be formal detention, might be treatment without consent or compulsory treatment. It might be seclusion, so we still have the use in many places of padded cells or restraint of people being tied to beds or having themselves put in some other form of physical constraint. And some of the early adopters of change and improvement, just as the adoption of changes and improvements occur sporadically around the world now, but the well-known figures in the history of mental health treatment of Philippe Pinel in Paris of the late 18th century, and then some of the moral treatment developments that were exemplified by John Connolly in Hanwell Asylum in Yorkshire in England in the 19th century. But some of these improvements can gain momentum and deteriorate just as we see today, and may or may not be more generalised. So with the help of some other colleagues that are here today, the colleagues at the Social Equity Institute at the University of Melbourne, including Piers Gooding and Bernadette McSherry and Yvette Maker, helped this task force to develop a discussion paper. And this is available online from the World Psychiatric Association's website. So if anyone has difficulty reaching it, let me know and I'll show it to you later. And I'll say too that the task force, I'll show you the full list of names later on, but several people in the audience have been part of this work, including our good colleague Robert and George Smukler and Nina Mashkavali. So most grateful for all your help. So we began also with the premise that there are growing calls for alternatives and that these are inherently part of improving service quality and safety, and that these calls are coming from within the professions, within the mental health professions and other helping healthcare professions, as well as among people with lived experience. So there's a commonality here to begin with. And there's also a growing evidence base to support the implementation of alternatives to coercion. And that evidence base comes from practice, clinical practice, service provision, from research into into services that have implemented reforms, and from work in international human rights law, as well as changes in national policy and legislation. And there are clinical and moral and legal grounds for alternatives to coercion. And all of the groups concerned, whether they be clinicians or people with lived experience or their families, have questioned the clinical benefits. What are they? Are there other ways for us to achieve safety and quality of care, and how feasibly can we put these into place? But the physical coercion does carry serious risks of injury as well as death, and the damage is there for the staff, for the practitioners, particularly for the nursing staff who often have to bear the brunt of the work. The moral damage as well as the physical damage of having to confine someone, knowing that there are alternatives, but not having access, not having the policy background in the service provision, not having the teamwork needed to work in different ways. And of course, the CRPD, the United Nations Convention on the Rights of Persons with Disabilities, and subsequent statements have challenged countries around the world, including probably most of our countries, to improve access to mental health, to supports for people living with mental ill health and related disabilities, and assist their recovery. All the positive rights that are to housing, to meaningful activity, to contact and connections, social connections, family connections. And that there's a call to prevent and to reduce and sometimes to end coercive interventions. Now, this, I think everyone here is also aware this is a subject of debate, that there are a number of practitioners as well as others have expressed reservations or reject moves. They say this is not a reasonable thing to do, and arguing that compulsory treatment needs to be available to protect people and others from harm, so there's so-called competing rights, to protect their other rights to the things we just talked about, to returning to home and to meaningful life, and to reduce, including the negative effects of some illnesses like mania or other forms of of ill health. But we also note that the different UN bodies have given different interpretations of some of the provisions of the CRPD, and some of these bodies share these concerns, and we need to work with what consensus there is. So that there are continuing debates. I think peers may have said to me, this is called the Geneva impasse, and there's in that the risk of debate about whether we can attempt to reduce coercion or eliminate it can become a distracting and completely debilitating debate. So in our task force, which included people with lived experience and people from a range of countries, the decision was that we look at the practical approaches. And also we could do that by looking at the agreement across the different perspectives on the overuse of coercion, that there is broad agreement that whatever our views might be about whether any form of coercion is the thin end of the wedge, as people sometimes say in English, or whether there is, on the other hand, such a pressing need for practical approach to change that we move forward with this work. And that there is also evidence and experience that we can use to support different approaches to implementing alternatives, to encouraging that teamwork and environment for good quality mental health care, whatever the level of resourcing available to services. And the sorts of changes that can be considered are those that are at a national level or high level, if you like, of policy change and legislation about mental health acts and about the resourcing of services. And then there are what to be done through clinical leadership and clinical example in services. How do we work with nursing staff, with psychiatrists, psychologists, social workers and others to change the environment and make families, people seeking service, seeking care, and practitioners comfortable with the alternatives and able to use these alternatives effectively. You might say, we'll come to it, but the nursing staff are often the key change managers in this, but we need leadership at all levels of clinical practice. And in doing this, there needs to be a clear goal to implement alternatives to coercion. So while much of the work and change will involve recovery-oriented care and person-centred care and care that's trauma-informed, all these elements are part of the move towards implementing alternatives to coercion. And there are a range of clinical change programs that have been put into place. I think you'll hear more about this with other presentations tomorrow, particularly from Piers Gooding. But safe wards, 6 core strategies, and the open door policy, all quite famous programs that essentially say, well, how do we manage to keep a calm environment, a positive environment, one that's respectful of people's rights and needs, where we collect information, we observe and document practice, collect data, and monitor through that the use of practices of various kinds. And a national policy with a stated aim to reduce coercion has been introduced in a number of countries, in Italy, in Germany, Switzerland, and other places, and in my own country in Australia. And we have the WHO Quality Rights Initiative that has given a lot of guidance and helpful direction to services and practitioners and all involved. But there are so far, there are a lot of limitations to the evidence base. Most of it relates to adults, people in the adult age group in hospital settings in high-income countries. And of course, that's a tiny minority, as remarked already, of the world's population. There's limited work with children and young people, with older people, with Indigenous groups, culturally diverse. How is it different for women and men and people with LBGQT, and how is it different in prisons? And the voice of service users isn't prominent in this work either. The other important consideration is what we do before or beyond, if you like, the hospital settings or the service settings. Intervening early in mental ill health is important, and intervening and having plans in place also for what people would like to have happen when they become unwell. And there's a great deal of work to be done on attitudes. If people expect to have to implement coercive measures in their general day-to-day work, they're much more likely to do it, of course. And if they don't have the, as I said before, the teamwork and facilities, they won't be able to do it either. And there's very little about this early intervention in the coercion literature. I don't expect you to read all the country names here or disentangle all these coloured lines, but it's a broad indication from a recent article in Lancet Psychiatry that variations in the patterns of involuntary hospitalisation in countries across the world, and this is the rates of involuntary treatment per 100,000 of the country's population. So it has all sorts of disclaimers or qualifications. We don't know how many inpatient or other service facilities there are in the different countries. We're looking at this in just in broad ecological terms. But you can see one of the countries right at the top has much higher rates per unit of population than the one at the bottom, and that, in fact, that's a comparison between Austria and Italy. And they're both advanced countries with progressive views on mental ill health, but it's a legacy in part of recent decades of policy and practice change. And unfortunately, my own country, Australia, is the second blue line from the top, despite us having very progressive views, as I would, of course, say. And this is another study from, in fact, the Western Pacific region. It includes Australia and New Zealand, as well as Japan and a range of the United States. So here we have the number of restraint events in mental health care per million population per day. Now, in New Zealand, I don't dare to press this button, something might happen, but the top right is New Zealand, where they have about half an event a day. And we look also at the fact that the y-axis has different scales. So when we look at below that, the Japanese prefectures of different types have between 250 events per million population a day. Oh, thank you. So thank you. We'll try. I'll try this one. Anyway, I think you can see. So there are 250 million events in one of the Japanese prefectures, and yet it varies a lot across those. as it does across the US states and the other countries. So it's fairly unlikely that this would be because of differences in rates of psychopathology. We don't expect there to be, 3,000 times the number of people living with severe mental illness in certain Japanese prefectures as in New Zealand. So the WHO Quality Rights Initiative, if we're thinking about how to redress the situation, how to change it for the better, we get a range of different guidances, and the Quality Rights e-training was released a few weeks ago, in fact, by WHO Geneva. It's available in 11 languages, and I'm sure it's in Russian, and uses a number of the ideas and programs that have been mentioned. And it's free to access, of course. So coming to the work of the task force, having looked at this discussion paper and having been involved in its creation, the task force undertook a consultation in the early months of the pandemic, in fact in 2020, with WPA member societies and asked them whether this was a question that was important to them, what was happening in their own countries and what their views were about the emerging recommendations of this task force. And at the same time, a member of the World Psychiatric Association's Service Users and Family Carers Advisory Group, which was set up in 2017, that what were their recommendations in consulting with service users and family carers. So the themes that came back from that consultation were that there was implementing alternatives was a unified, was a way of unifying the various member societies of WPA. I mean, we didn't get that many responses, but we got responses across all four big major regions of the world. And of those that responded, nobody said we shouldn't be doing this. They all thought it was important, and perhaps that's why they answered. But there was strong agreement that mental health practitioners needed to take a lead, whether they be psychiatrists, psychologists, nurses, but all needed to take a lead, speak to others about it or take leadership themselves, whatever their particular role in a service or in a country system was. They need to connect with that. It was important to connect this initiative with recovery-oriented care, so that one went with the other, as with trauma-informed care. And that there needed to be meaningful involvement of service users and family carers. This, by the way, being another question, that terminology was the preferred one from our advisory group to the difficult question of how to describe the role of people with lived experience. And that the barriers and challenges were similar, whether it was a high-income or a low-income country. Lack of resources, relative lack of resources, as we know, is almost as difficult to manage as absolute lack of resources. But and the culture, people. Often the psychiatrists or the nurses would express frustration that they couldn't do things differently, that they were forced to have to confine people. In my own country during COVID, there's been a rise in a very unfortunate practice of restraining people to their cot in the emergency department of hospitals. And this is highly unsatisfactory, not only lack of resources, but also lack of leadership and lack of imagination in certain places. And there needs to be the political will overall, as with having the Minister of Health from Lithuania here today, is a very encouraging sign, but that leadership needs to come from the top as well as from each service. So the position statement implementing alternatives to coercion was published in 2020, and there was a paper in World Psychiatry 2 years after that. It was endorsed by the WPA General Assembly, which is its overall meeting of the 140 societies. And that the background was that psychiatrists have substantial roles in implementing change, and that there's a lot of work to be done to ensure access to high-quality mental health care and support. It's not just simply a decision, it's sustained work with a range of partners over many years. And that there's a call for action for psychiatrists and all other partners in each setting to work together to look at the local evidence for the experience of alternatives and identify feasible changes and make a to-do list of specific actions, whether that be in policy, in culture of a service, treatment activities, research and evaluation, and probably a number of those. And the next steps have been to develop case studies at the local level, at different states of countries and nationally, consult with member societies in a continuing way, and to share experiences between the societies. And this, the development of information, resources and training is ongoing and becoming available online. So one of the case studies available online is from Quality Rights Gujarat. I won't go through it in detail now, but it does show what's possible in a low-income setting. And this was conducted led by Dr. Sumitra Patari with the Indian Law Society and the World Health Organization, and involved service users and family carers working with professionals, many of whom had their eyes opened. So to conclude, working with the member societies of the World Psychiatric Association, it's been determined that alternatives to coercion can be implemented with partnerships and support. And in fact, this resolution and this clear objective is an essential element of moving to recovery-oriented care, which is another recommendation from the World Health Organization. The challenges are leadership, and developing through that leadership a united approach at whatever level, whether that be looking at individual attitudes and understanding, to teamwork in services, to service policies and development and national directives. And translating success factors across settings so that some of the larger member societies of our association can work with smaller ones, each of those in turn working with their own community groups and partners. And that measurement and benchmarking needs to be developing data and developing research and evaluation monitoring, and providing resources for training, education, and for that evaluation and research. And WPA, through the current president, Professor Afzal Javed, has invited this group to continue. And there is a consultation going on currently that we hope will increase that interest. So here's a list of people involved, including a number of those that I mentioned earlier. And the work was supported for the first 3 years financially and in kind by the Royal Australian New Zealand College of Psychiatrists, by a project organisation Community Works, and by the Melbourne Social Equity Institute at the University of Melbourne. And there is now a working group continuing with this work, together with the Service User Family Carers Advisory Group and the Association Standing Committee on Ethics and Review. The RANZCP has continued its financial support, and the Japanese Society for Psychiatry and Neurology has promised and provided financial support. And we are, in fact, we hope, in the early stages of crowdfunding. So a number of the other member societies involved in this working group have undertaken to bring this back to their societies. And as more get involved, more are encouraged to see this investment as very cost effective. So I thank you for the attention.